Hello everyone, I'm David Farzam. Welcome to New Cancer Mentality. New Cancer Mentality is a place where cancer patients and their families can come and get information in terms they can understand and to help everyone learn about the newest trends emerging in the cancer field. Today we're extremely fortunate to be interviewing highly acclaimed thoracic surgeon Dr. William R. Smythe. Dr. Smythe completed his medical degree at the Texas A&M Health Science Center School of Medicine and later went on to do a surgical internship at the hospital of the University of Pennsylvania in Philadelphia, followed by a surgery residency. He then completed a postdoctoral research fellowship in thoracic and molecular oncology in the Harrison Department of Surgical Research at the University of Pennsylvania. He then completed another fellowship in clinical oncology from the American Cancer Society and earned the title of Chief Resident in Surgery. Dr. Smythe is certified by both the American Board of Surgery and the American Board of Thoracic Surgery. Dr. Smythe has received a number of awards, including the Consumers Research Council, Best Surgeons in America, and the Ali Sheridan Scholar from the Kennedy School of Government at Harvard University. Currently, Dr. Smythe is the chairman of the Department of Surgery at Scott and White Memorial Hospital, as well as the chairman of surgery at the Texas A&M Health Science Center College of Medicine. He holds the Glen and Rita K. Roney Endowed Chair in Surgery and is a professor of molecular and cellular medicine for the medical school. Thank you again for being with us, Dr. Smythe.
It's great to be here, David. Thanks for having me.
So first off, what got you interested, Dr. Smythe, in going into cancer research and becoming a thoracic surgeon?
Sure. Well, for me, David, those are really two separate processes. I actually have been interested in cancer research since I was a young person. My mother was a cancer patient. She actually developed a brain tumor when I was quite young and died when I was a teenager of a sort of a rare adult brain tumor. And so I always had sort of this thing in the back of my mind that I might do cancer research or cancer treatment at some point in my life, and decided at a very young age I wanted to be a physician. As far as thoracic surgery, that really had to wait on my exposure to the different surgical disciplines when I trained as a general surgeon, where you get exposed to thoracic surgery, cancer surgery, plastic surgery, and so forth. And I just like the anatomy of the thorax. I like the medical management of thoracic surgical patients, and so I gravitated in that direction.
Could you define mesothelioma for our audience? What is the difference between pleural and peritoneal mesothelioma?
Sure. Mesothelioma is a tumor that arises from the mesothelium. The mesothelium is a layer of tissue that covers the lung, covers the lining of the inside of the chest. It also covers the intra-abdominal organs and the lining of the abdominal cavity. The tumor arises from one of those surfaces, or at times all of those surfaces. And pleural mesothelioma implies that the tumor arises in the chest. That area where the lung resides, where the mesothelial tissues cover the surface of the lung and line the inside of the chest wall, is called the pleural cavity. The cavity within the abdomen where the abdominal organs reside, the intestines, liver, and so forth, where that same tissue covers those organs and covers the lining of the abdominal cavity, is called the peritoneal cavity. So pleural mesothelioma is a tumor that originates on one of those surfaces in the chest, and peritoneal mesothelioma arises on one of those surfaces in the abdominal cavity.
Could you go over the common symptoms of a patient suffering from mesothelioma?
Sure. Well, obviously it depends on the site of the disease. For pleural mesothelioma, most patients present with shortness of breath. The tumor will grow, fluid will collect as a result of the tumor growth in the space around the lung. The lung will be compressed, and so patients will develop shortness of breath. I would say about 80% of patients that develop pleural mesothelioma, that's the complaint that takes them to the physician. You can also get chest wall pain, but that's really not early in the course of the disease, and a large number of patients will never really have pain early on in the course of the disease either. That really requires the tumor to invade the chest wall or the nerves that line the chest wall. In the abdominal cavity, one of the problems with peritoneal mesothelioma is that you have to actually accumulate a lot of fluid in the abdominal cavity because there's a lot more room there than there is in the chest, and it takes a lot of fluid to compress the abdominal organs to make you symptomatic. So oftentimes it will be a feeling of fullness. Patients that develop, they get full early when they eat, something called early satiety, or in some cases, again, abdominal pain. About 85% of mesotheliomas arise in the chest and about 15% in the abdominal cavity. So by a factor of about 7, most of them arise in the chest and pleural cavity.
How do most patients get malignant mesothelioma to begin with? I hear a lot in the news that has to do with asbestos exposure. Could you elaborate on that?
Sure. So we know that about 80% of patients with mesothelioma have an objective, substantiated, significant exposure to asbestos at some point in their life. So about 20% do not. What we also know is if you take that 20% of individuals and have an industrial hygienist or a well-educated lawyer or physician that deals with patients with mesothelioma interview them, they will find an exposure somewhere in their background. So really the number is probably closer to 90% of patients have some significant exposure to asbestos in their background. But this is not, this is not the, I went to school in a building that was old and had asbestos in the walls. These are people that worked in asbestos-related industries, shipbuilding, insulating, refinery work, brake pad grinders, and those sorts of jobs. Or on rare occasions, unfortunately, people that were married or related to those individuals when they brought the asbestos home in their clothing. As far as the other 10 to 15% of people that develop mesothelioma without a history, that's a bit of a mystery. We know that there are some familial syndromes, genetic syndromes that can predispose you to this disease as well. But those are very rare, and there's also quite a number of them. There's no real consistent genetic abnormalities that are found in families like some other diseases like breast cancer or ovarian cancer.
What are the common diagnostic tools you use to search if a patient has malignant mesothelioma? Do you use a surgical biopsy, a CT scan? Could you elaborate on that?
Sure. Well, I guess the first point to make is that we don't screen large numbers of people for mesothelioma, even those that have been exposed to asbestos. If we have a clinical suspicion that someone might have mesothelioma, we usually start out with a CT scan of the chest. Mesothelioma has a very characteristic appearance on a CT scan, different from benign thickening of the pleural surface, different from some other malignancies of the chest. We then might get a PET scan or positron emission tomography scan to see if the surfaces light up that are thickened, indicating the likelihood of more likely that the thickening is related to a tumor. But then at some point along the pathway, we always are required to get some sort of biopsy in tissue. In the past, when I was training in thoracic surgery, the textbook said that you had to get 10 square centimeters of tissue for the pathologist to look at, which required obviously an operation. But nowadays, a good pathologist with a good core needle biopsy, or even at some referral centers, just the fluid alone that's in the chest and the cells that are floating in the fluid can render a diagnosis of mesothelioma without having to do a significantly invasive procedure.
What are the treatment options you currently use to help patients with malignant mesothelioma? How do you determine which treatment regimen is best? Is this somewhat determined by the stage of their cancer?
Yes, that's a good question, especially the second part. We've known for at least 25 years that most other solid malignancies in adults, breast cancer, colon cancer, lung cancer, that require that the patient be staged. Staging is a process by which a surgeon or a medical physician treating a cancer patient will determine where the tumor is located, how big it is, what surfaces it's invading or areas of the body it's invading or organs, and then whether or not the tumor has spread to lymph nodes or other areas of the body. For mesothelioma, we really didn't understand the staging of this tumor until about a decade ago. So one of the sad facts is that there were a number of patients that were either deemed untreatable, who were not appropriately staged, and then probably an equivalent number that were treated with advanced stages of disease that should not have been treated with aggressive therapy. But in the last decade, we've become much more facile with a staging system and ways to stage patients. And so the first determinant, of course, is do you have mesothelioma, because other things can look like it. The second is what's the stage of the disease. The third is, what are you capable of tolerating as a patient. Many patients with mesothelioma are in their 60s, 70s, or even 80s, owing to the epidemiology of exposure to asbestos before its use was outlawed in this country routinely. So the third consideration is always not only what is the tumor, how substantial is it, but what sort of therapy would you be able to tolerate.
How much do you tend to interact with your colleagues at Scott and White before determining which form of treatment will be suitable for a particular patient?
A fair bit. Scott and White is the fourth largest group practice in the country, and multidisciplinary care has been the norm here for decades. And so any patient with mesothelioma would likely be evaluated by myself, at some point along the line by a medical oncologist, and also by a radiation oncologist. The treatment protocol that we use here for young patients, especially younger patients that could tolerate all modalities of therapy, would include all of those types of therapy. It would be chemotherapy before surgery, followed by surgery, and then a form of radiation therapy called IMRT, or intensity modulated radiation therapy after surgery. So it's pretty rare that I make a treatment decision in a vacuum. We at least consult, if not all see most of these patients when they come here.
What can most patients expect after being treated for mesothelioma? How long does it usually take before they can resume normal activity?
Well, obviously, what patients can expect after treatment depends entirely on the type of treatment that they receive, and then how functional they were before treatment as well. So, if a patient undergoes chemotherapy alone, probably about 70 to 80% of those patients do very well and are able to resume, or even during the course of therapy, enjoy a fairly normal daily activity. Patients undergo surgery. It depends on what type of surgery they have. If they have a pleurectomy where the tumor is just stripped off the surfaces, they may be able to get back to normal activity more quickly and have a lower risk of adverse effects of the operation. But that operation leads to higher rates of local recurrence. So those who have the larger operation done, called an extrapleural pneumonectomy, where the tumor is removed along with the lung, the diaphragm, and the pericardium around the heart, and then those things are reconstructed. A little bigger operation, a little longer time to recovery, and a greater chance of complications. I would say most of the patients that I treat, even if they get both chemotherapy and the larger operation, about 85% of them are back to relatively normal activity within 2 to 3 months. Unfortunately, about the time that they recover from that, we like to initiate the radiation therapy part of the treatment, the intensity modulated radiation therapy. And the side effects for that mode of therapy are not severe in 98% of patients, but there is fatigue, some burning of the skin in some patients, and in rare cases some nausea that go along with that. So I like to tell my patients that the treatment is not easy. It's a commitment for a long period of time. But that the potential upsides are prolongation of life and at least a chance, although not a high chance, but at least a chance for cure.
On that note, what are your thoughts in regards to when the radical procedure, extrapleural pneumonectomy or EPP, should be used versus using the less radical treatment, which is a pleurectomy and decortication? Is that correct?
That's correct. Well, there are about, I think, 12 or 15 surgeons in the country that routinely operate on patients with mesothelioma. When I say routinely, I mean more than a handful of times a year. And the camp is somewhat split between those groups of surgeons about which type of operation to proceed with in patients. There are those that feel that an extrapleural pneumonectomy should never be done, and there are those that feel that a pleurectomy should never be done. The problem with the pleurectomy in most patients is that, number one, the local recurrence rates are high, and number two, the types of treatment that you can apply to the tumor after surgery are a bit more limited than if you remove the lung. In our protocol here, because we use IMRT after surgery, intensity modulated radiation therapy, a modality that we pioneered when I was at MD Anderson with Craig Stevens, who's now at the Lee Moffitt Cancer Center as the chief of radiation oncology. We've seen a significant drop in local recurrence compared to other types of treatment, but then in order to have that treatment, you have to remove the lung. And so what my bias is that I prefer to do the larger operation, but I'm fairly selective in regards to who I do that operation on. I like to limit it to patients with epithelial tumors, if possible, those that have no evidence of nodal spread in the chest, obviously no spread to other areas of the body, and then a level of underlying heart and lung fitness that would allow them to tolerate that. I do pleurectomies as well, but my goal is to evaluate people for the extrapleural so that they might be able to have IMRT afterwards.
Getting into your research, you fairly recently published an article looking against the drug bortezomib. Could you give a little background on the methods used to develop a novel resistant line from the mesothelioma cell line I-45 and the results you obtained? Is there a way for other scientists to target these resistance mechanisms you found in the future?
Yes, there certainly are, and really the concept of developing resistant cell lines is not new or even necessarily novel. The way that this is done, there are a number of ways to do it. The most reliable way, at least in our hands, is to take a cell line and expose it repeatedly to a chemotherapeutic or biologic agent over time, and knowing that in the petri dish that there'll always be a population of cells that aren't killed by the treatment. What we then do over and over and over again, sometimes for months or even years, is take those cells that survive, treat them again, take the cells that survive after that treatment, treat them again until we develop an entire line of cells that are resistant to the initial treatment. If you believe in evolutionary biology, it's basically forced evolution of cancer cells over a short period of time. The cells that adapt, or the cells that happen to have a genetic profile to be resistant, will eventually be the predominant cells in culture. And then this allows you to have a cell line to compare with a specific treatment, like with the proteasome inhibitor bortezomib, that have a sensitive line and a resistant line. And you can begin to ferret out the mechanisms by which the cell has developed that resistance. And that's what we did in this set of experiments. And we've done that with some other types of treatment as well over the years.
Excellent. On that note, on a previous New Cancer Mentality webcast, we had Dr. Arnold Glazer, who's at Johns Hopkins. He spoke of targeting normal cellular machinery patterns in cells that can give rise to proliferation and invasiveness. Would you agree with this concept, and can this be done on mesothelioma cell lines in the future to develop targeted drug therapy?
That certainly is a possibility. The problem with targeting normal mechanisms in the cell is that you certainly run the risk of increasing the toxicity of the treatment. So you have to find those normal mechanisms that can be targeted in normal cells without side effects, or those normal mechanisms that for one reason or another are more sensitive to treatment in cancer cells. So I certainly agree with the concept. The interesting thing about cancer cells in general, when it comes to biologic treatments, and that's really what you're talking about here, rather than the conventional chemotherapy agents, which I always tell my medical students and postdocs, it's like breaking eggs with hammers, is that biologic therapy tends to be focused on one discrete abnormality in a cell, or at least a family of abnormalities. The problem with most cancers is they've accumulated hundreds, if not thousands, of abnormalities over time. So what we're always looking for are the one or two abnormalities that we can target where it doesn't make any difference what the other abnormalities are. The Achilles heel of the genotypic or phenotypic abnormalities that have accumulated over time. The beauty of biologic therapies is that there are some cancer types that have very specific genetic abnormalities that we know are the Achilles heel for that cell's growth and invasiveness, but many do not have those. And cancer cells are very smart. One of the things I've always been interested in is the ability of the cancer cell to react to treatment. To upregulate, if you attack a certain gene, what we see in our work when we're targeting anti-cell death genes, anti-apoptosis genes, is when we target one gene, the cell will actually increase the transcription of another gene that does the same thing. And so cancer cell is a formidable foe, has a number of defenses.
Getting a little bit more into your research, you recently also did a study showing that upregulation of BCL-XL by hepatocyte growth factor in human mesothelioma cell lines involves ETS transcription factors. Could we in the future target the hepatocyte growth factor receptor c-MET and BCL-XL to give better treatment to patients? Could you explain to our audience what these factors do and what was the correlation you found as a result of doing this study?
Sure. So one of the things that cancer cells don't do compared to normal cells is, and it's going to sound somewhat trite, but they don't die. And they don't die when they're supposed to die, and they don't die under the same influences that normal cells die under. So there's a process called programmed cell death, and it is exactly what it says. Most cells are programmed to die at a certain time. That's what happens when we age. It's actually an important mechanism in the immune response to eliminate cells that don't recognize foreign antigens and to upregulate those that do. It's important in the development of embryos. The morphogenesis of human beings depends on certain cells dying at the right time. But cancer cells have often lost their regulatory mechanisms that tell them to die on cue. And so this line of investigation with the hepatocyte growth factor was related to the fact that one of the proteins that, when it's expressed at high levels, keeps cells alive and prevents programmed cell death is BCL-XL, a member of the BCL2 family. The BCL2 family has a number of proteins that want to force the cell toward a death pathway and those that want to prevent it. And the ways that they do that are quite complex and not necessarily need to be ferreted out here, but the important concept is BCL-XL is one of those that wants to keep cells alive when it's expressed at high levels. As it turns out, a number of malignancies overexpress this protein BCL-XL. And mesothelioma is one of those. And so over about a 2-year period, we worked to determine what drives the overexpression of this protein in the cancer cell. And what we found is that actually what drives it is the hepatocyte growth factor, or hepatocellular growth factor, HGF, which binds to c-MET, as you said. And it appears that for mesothelioma that both the receptor is upregulated on the surface of the cell and that the growth factor itself is upregulated in the milieu of the tumor. And this actually directly drives production of BCL-XL through BCL-XL, the switch that turns it on in the cell called the promoter. So the reason we look at the pathway like this is that we're trying to find, again, that Achilles heel in the pathway. We've done a number of experiments to downregulate BCL-XL itself, to downregulate expression of BCL-XL, to block BCL-XL's ability to bind to its targets in the cell using competitive small molecule inhibitors. But this would actually allows us perhaps to find an upstream target. In other words, either blocking the c-MET receptor or interfering with HGF activity may allow the tumor cell then to be more sensitive to cell death by downregulating the expression of BCL-XL before it's upregulated at the promoter and make it more sensitive to conventional treatments. What we find is that when you downregulate BCL-XL expression or you block its effect, that normal chemotherapy drugs like cisplatin and Alimta and so forth that are marginally effective alone become very effective both in vitro in the petri dish and in animal models of this disease. So the goal here is to render the cancer cells more sensitive to conventional treatments.
Don't these proteins and factors, though, undergo the same evolutionary mechanisms as most other proteins in the sense of what we were saying earlier?
Absolutely, absolutely. So when we downregulate B-cell XL in cancer cells, it's sort of a race. In other words, can we hit the cell hard enough before it can respond to kill it? And it appears that often we can, but sometimes we can't. A number of the other anti-apoptotic proteins are upregulated when we downregulate B-cell XL or block its function. So that leads to other potential treatment strategies such as targeting multiple proteins at one time, or as I said, sensitizing a cell, knowing that you're not going to knock it down completely, but if you lower the threshold for death just enough, then a conventional treatment might work. But there's no doubt that the cell responds. You know, I'm not going to say that cancer cells are smart, but from the standpoint of how they react biologically to threats, they appear to be. One of the other things that cancer cells will do, and we found in mesothelioma, is that there's actually more than one type of programmed cell death pathway. There's programmed cell death type 1, which involves apoptosis, which has both an intrinsic mechanism where the changes in the cell to lead to cell death start within the cell, and those that start extrinsically from the surface of the cell with death receptors. There's also a type of programmed cell death called programmed cell death type 2, or autophagy. Autophagy is just what it sounds like. It's auto-eating. So the cell, under nutrient starvation or other stress, may begin to consume its own organelles in an effort to conserve energy. If that's taken to its logical extreme, obviously the cell dies. I mean, if you don't eat, if you go on a hunger strike and don't eat for 10 or 14 days, the likelihood of survival is low because you actually auto-digest your own proteins as a human being. So the cancer cell, if pushed hard enough in autophagy, will eat itself and die. What we found is that when we stress the cell and push it towards apoptosis or programmed cell death type 1, the cell turns on the autophagy program, begins to consume its own organelles, and some of the cells do this to sort of ride out the stress. They lower their metabolic demands, they remove the organelles that are damaged from apoptosis, and some of those cells survive. And so there's a number of ways that cells react to biologic therapies. Right now there is no silver bullet for most cancers, and what we're left with is people that are looking at translational therapeutics for a number of different cancers is how do we lower the threshold for death so that other therapies work better, or what therapies should we put together, such as something that may trigger programmed cell death type 1 and programmed cell death type 2 at the same time in order to outsmart this evolutionary process that the cell goes through.
A lot of interesting things going on, that's for sure. On a more general standpoint, how difficult is it for findings taking place in the laboratory to translate into potential new treatment options for patients in the future? I know there's a long lag period. Could you elaborate on this a little bit?
Yeah, I think it's a major problem, actually. And so I have some experience in another area. I'm a co-founder of a biotech company that has developed a biologic treatment for vascular permeability states, and when patients have bleeding or sepsis or many other disease states, what happens actually is the final common pathway to death is the blood vessels get leaky and they don't hold fluid, and so working with another lab here, we developed a biologic treatment for that and developed a startup company around that, and I can tell you that the impediments to moving something from the bedside to the bench and back to the bedside are considerable. There's a gap in the funding mechanism for new treatments. First of all, most of the funding for the initial basic science work that's done for therapeutics obviously comes from the federal government, most from the NIH, some from the Department of Defense and so forth. We all know that those budgets have not grown to keep pace with the demand over time. Right now, if you're a new investigator and put a grant into the NIH, you've got about a 1 in 10 chance of getting that grant funded, and slightly lower chance if you're an established investigator. Of course, it depends on which branch of the NIH that you apply to, but the odds are low. And so even if you can get that part of your research funded, have a good idea for a cancer treatment, looks good in the laboratory, and you've done those experiments, and now you want to take that to the clinic, now there's a gap in the funding. There are some federal funding programs for that, the SBIR mechanism and others for the NIH, but again, it's very competitive and a number of good ideas are not funded, and so what you're left with then is venture capital funding, other types of funding which tend to ebb and flow with the health of the economy. And so there's the financial impediment. There's also the impediment of time. Patents take a long time to be approved. There's the impediment of regulatory oversight for clinical trials and toxicity and so forth, all of which are necessary. But they are very laborious and take a long time. And so the average time for the average good idea, the possibility of a good idea going from a neurotransmitter discharge in someone's brain to a patient's body is, I'd say, about a 1 in a million chance. And the time that it takes you to realize that on average is between 10 and 15 years for most new drugs. Now there are exceptions and have been exceptions. And so I'm not criticizing the regulatory mechanisms or their goals. Patient protection is important, and we will all be patients someday. But I do feel some urgency to streamline the process of approval and development of important, promising drugs in this country. In other parts of the world, things tend to move along at a little faster pace.
I do agree that we definitely need to get more funding involved, especially in cancer research. Dr. Dooley, who's, I can't remember where he's from, I think he's also from Texas A&M, he stated to us that with the money allocated towards cancer research is very slim if you consider it towards the price we pay for wars and other common general ideas. So, so that was good to hear from you.
Oh yeah, no, and I fully agree with that. I'm obviously I'm not here to comment on politics or government, but the one thing I can say with great assuredness is that the money that it takes to buy one B-2 bomber could get a lot of science done.
What do you think can be done in regards to the information overload of so many papers being published nowadays? How does the general cancer patient go about reading all of this and formulating their opinions on what they should be looking at and what they shouldn't be looking at?
That's a really good question. That's something I think about a lot with mesothelioma patients, actually. There's a lot of information out there. There's some misinformation out there. And the density of the information is daunting. So I think that the good news is that there's a lot more information available than there ever has been. 20 years ago there was no internet. There were no National Cancer Institute websites or other reliable websites to go to get information. And the medical journals are difficult to ferret through, even for someone who knows what they're reading. So the good news is there's a lot more information out there. The bad news is, just as you said, is it can be overwhelming. Which information do you use? What does it mean? I think the most important consideration for a patient is to find a well-informed, expert physician that treats the disease. And especially for more complex types of cancer, to find someone who's experienced and who focuses their career on that literature. I know that takes somewhat of a leap of faith, and I'm not telling patients that they should not pursue all the information sources that they have at their hands. As a matter of fact, what I like the most as a cancer treating physician is someone to come that has been on the internet and has developed a series of questions to ask me where they're confused or where things don't make sense or where the terminology was not clear to them. I actually find those discussions to be more productive than someone who comes with no idea whatsoever of what their problem is. But I think in the long run, the best way to make sure that you're getting the best treatment is to educate yourself as you can, understanding that the information is dense, and then find an expert. Find someone who has dedicated their career to that area of treatment to serve as your final filter for decision making.
How individualized do you think cancer treatment should be? Each time you perform surgery, is it generally different?
I think the first comment to make about surgery for cancer is that we're always trying to eliminate the need for that. John Hunter, who's the father of surgical experimentation, who was an English surgeon and anatomist in the 18th century in England, said surgery is what a savage would get by force that a civilized man would get by stratagem. And so the first concept is we're always trying to eliminate the need for surgery in anyone in the future if possible. The second is obviously everyone's anatomy is different, everybody's tumor is different. There are very few patients that have exactly the same problem. There are certain steps in the operation that should be done in a standardized fashion to do it in an efficient manner. But experienced surgeons that have seen a lot know that no two operations are alike, and that the likelihood of any operation deviating from the last one is about 100% to some degree. As far as individualized therapy in general for cancer patients, however, unequivocally, at least in your children's lifetime, David, and you're a lot younger than me, but at least in your children's lifetime, I think that we'll see individualized therapies for most diseases. I think the advances in whole genome sequencing, in metabolomics, in proteomics, the advances in systems biology will allow us to identify individual patient patterns rather than patterns in large numbers of patients related to their histologic microscopic diagnosis. We'll look for molecular patterns of tumors that dictate how they're treated rather than what we do now. We're in that transition period as we speak, but it's going to take a while to get there. But I have no doubt that the days of treating 100 lung cancer patients with the same blunt instrument of cytotoxic chemotherapy that we do now will go away during your children's lifetime, if not sooner.
How important do you see prevention being on mesothelioma? We already spoke about asbestos exposure and how patients should attempt to stay clear. What other preventative factors do you know of that could potentially play a factor in patients getting mesothelioma?
Sure. Well, mesothelioma is a very poor poster child for prevention at this point in time because one of the strange things about this tumor is that virtually everyone that was exposed to asbestos was exposed to asbestos in the distant past. In this country, routine asbestos use was outlawed in the late 1970s and early 1980s, sort of sequentially. No way to go back in time and prevent having been exposed to it in a job or in a related industry. This disease is not a good disease, I think, to pick for prevention in this country. That being said, there are a number of developing countries around the world that have not regulated asbestos exposure to any degree whatsoever. And there are some developed countries that still export asbestos for that use that have outlawed it in their own countries for use. So there continues to be a global problem. Some countries that might surprise you, like Russia, do not heavily regulate asbestos exposure. And again, the developing countries around the world that you would probably know to list yourself have not regulated its use, some of which are undergoing great industrial revolutions like we did at the time many of our patients were exposed. So prevention measures for mesothelioma should be directed at this point to those countries. I also think that the export of asbestos for unregulated use in other countries should be scrutinized by those governments that do that.
Great. So the final question I'd like to ask you before we let you go today is there any piece of advice you could give to patients from all your experiences that could potentially help them if they're never able to meet somebody of your caliber who could potentially treat them of their disease?
Well, there are hundreds and thousands of physicians in this country and around the world that are just as competent as I am, or more so. You know, do your homework. Again, there are resources available that weren't available 20 years ago for you to learn about your treating physician. So go online, look to see if they've written anything about the disease. Talk to other patients that have been treated. Talk to other physicians that you know. Oftentimes your family physician is your best resource in your community. And then the last thing is to ask questions. Ask questions. For the more prevalent cancers such as breast cancer and colon cancer and so forth, the likelihood of having a practitioner within 40 miles of your place of residence that's quite competent is high. But do those things, you know. Get the information that you can get yourself, and then ask your family physician or your local doctor that sees you on a routine basis who they would send their family members to. And then for the more unusual cancers, don't be afraid to look beyond your local community if necessary. But again, the important thing is to gather as much information as possible.
So thank you again so much, Dr. Smythe, for being with us today. I can't thank you enough for your time, and if there's anything we can do in the future for you, don't hesitate to ask. We really thank you for teaching us today and all the information you shared. So thank you again, and I truly do appreciate it.
It's my pleasure. Thanks so much for having me, and I hope a few people get slightly better cancer treatment for your efforts. Thanks so much.